So this is with the basic difference between the CO2 laser and the KTP laser. And what are the benefit, as I described previously? It cut precisely layer by layer and very good on the soft tissue, especially the laryngeal mucosa. If you use it in a mode which I told Ravi Kishore was asking what are the characteristics, settings. So for benign lesion or even early malignant lesion, use ultra pulse, super pulse mode. And all these modes are preset in the machine itself. Only thing, you have to change the buttons or the switch and the size of the beam, or shape and size of the beam can be altered according to your comfort and according to, or if you use these surgeries with superior and ultra pulse mode. And coming to the attachments, so CO2 laser is a versatile which has got multiple instruments or multiple accessories for multiple sites in the ENT. So namely it is hand attachments, especially for oral cavity and the oropharynx, where there will not be scanner here. So directly the laser beam can be used on the tissue with the hand attachments. So this is best suited for oral cavity and oropharynx lesion. And the scanner mode, free beam scanner mode, which is good for especially laryngopharynx. So through the laryngo, the beam will be passed through the laryngoscope and hit on the surface of the tissue. And through a fiber mode, that is another mode wherein for subglottic and the lesions on the trachea, you cannot use a free beam. Free beam will not reach in the subglottic region or the trachea. Fiber mode is the best for all subglottic and tracheal lesions. And this is the photographs. And these are the handmade applicators with different sizes. It is available for lesions on the oral cavity and the oropharynx. You can see here the arm is directly connected to a small oral applicator with a different wavelength. So the laser beam directly hit on the tissue. And next is the free beam mode, wherein you have a coupler to the microscope where the laser beam can be scanned through that micro manipulator, which can get coupled to the microscope, and you have a scanner into that micro manipulator. So the laser beam travels, once it comes out of the microscope and manipulator, it will travel through the laryngoscope and hits the surface of the tissue. So this is free beam under scanner mode. And of course, this you need any transoral microlaryngeal laser surgeries. You need a multidisciplinary team with an institutional background. So most important is multidisciplinary. It's a multidisciplinary team. You need a backup, institutional backup for all TOLM, in short form TOLM. And a good, you should able to collaborate before and during the surgery with the anesthetist is very, very important. And third thing is, as Akshay said, pathologist. Especially you are excising the pre-malignant lesion or a malignant lesion on the vocal cords. You can excise with the normal margin as he described, so that you can discuss with the pathologist why is important. During the surgery itself, to know whether the margins are free or not, you can directly discuss with the pathologist, send the specimen for frozen section on the table. If you have a doubt that you are not excised or you are excised the lesions completely, So discussing with the pathologist and you have collaborate with the pathologist is very important in transoral microlaryngeal surgery, and a good nursing team, of course. And last but not least is the post-operative rehabilitative team, speech therapist or solo therapist. So this it is a complete multidisciplinary team is required for all transoral microlaryngeal surgery. And this is the setup. Of course, the laser machine usually ideally it is on the left side. It is always, of course, it is surgeon's preference or surgeon choice, and the right side will be on the microscope, and ideally will be on the back of the head and table. Laryngoscope. So any transoral microlaryngeal laser surgeries, laryngeal exposure is very, very important. Without proper laryngeal exposure, you cannot do the transoral microlaryngeal surgery precisely. So ideally, wide bore laryngoscope, DIDO laryngoscope, which is available in the market. It is an ideal scope which is very important for laryngeal exposure. Morning, sir. Satyananda, sir. So ideally, wide bore laryngoscope is very, very important for laryngeal exposure. So you can get it in from any surgicals, but ideal is the DIDO laryngoscope from the stores, because the advantages of having this scope is it should have a carriers. One is for the light and another is for the plume or smoke evacuation. So in laser surgeries on the larynx, evacuation of the fume is very, very important, because it will come in the way of field. So it has got a carriers like you see in the picture. So two carriers will be there. One is for the suction to evacuate the fume and another is for the light carrier. Once the light carrier is out during the procedure, the same the port can be used for the second suction. So second thing is when you are operating supraglottically, any lesions on the supraglottis. So you need to have a wide bore, especially the distal end of the scope should be wide bore. Ideally is the Lindholm, and of course, and lesions on the supraglottic, the angled instruments with the coated for cautery and a suction with the attached suction is must for transoral microlaryngeal laser surgeries. There is a small video wherein it's another 1-2 minutes I'll get over. It's okay. And as I said, preoperatively assessing there are laryngeal predictor to anticipate the difficult exposure of the larynx. So in a case of difficult larynx, or if you have anticipate preoperatively a difficult larynx, like you should always have a small bore laryngoscope. So in a transoral microlaryngeal surgery, laser surgeries, this is another additional armamentarium. Keeping a small bore laryngoscope is a must, so that in case if it is a difficult one, you can go ahead with the procedure with using a small bore laryngoscope. So this was a difficult laryngeal case wherein we used a small four laryngoscopes and we could finish it up the procedure well. And of course, these are the minor instruments. For holding the tissue, the ideal serrated edges, which is an atraumatic, that is ideal for holding the tissue while doing laser microlaryngeal laser surgeries. And these are the, when you are operating on the subglottic and tracheal in the trachea, these are the handmade steel, handmade the handmade steel handmade materials with wherein you can pass the fiber to operate on the subglottic and laryngeal trachea. And in a transforal microlaryngeal surgery, before your surgeon, this is, I think Akshay has already described it, hydrodissection and submucosal infiltration, injection of the saline at the junctions of the, between the pathological and the normal tissue. There are two important advantages by doing this is, it prevent the normal tissue from collateral damage, and second thing is, it will define the plane between the normal and pathological tissue. So this is very important in transoral laser microlaryngeal surgeries. Lastly, golden rules for all laryngeal laser surgeries is wear a wavelength specific goggles or glasses, and for the patient, eyes should be covered with the glasses which was provided with the machine itself, and cover again with, before the spectacles you cover eyes with the wet gauze and then the spectacles, as we did in the previous case, and cover the face and the anesthesia tube, because anesthesia tube is highly inflammable, highly combustible because of the gases which circulate through the tube. So cover the all this anesthesia tube connections with the wet towels, and the face also, patient's face should be covered with the wet towels. And keep it in mind, the handpiece of the laser handpiece is not a pointer. If not in use, deposit handpiece safely. Don't use it on the surgical instrument. The laser beam should not be used on the surgical instrument. It can reflect back and causes injury. And don't laze on the combustion materials, like as I said, especially the tubes. And this is most important, last one is the cotonettes and pledges should be repeatedly moistened during the procedure, laser procedure. So with these golden rules, you can, we can go ahead and do the surgery safely, especially when you are using a laser. With these few talks, I think I will end my session. I thank my teachers again, Hegde sir, Satyananda Rao sir, and Manjunath sir, Shankar sir, and Dhananjay sir, and my seniors, Ravi Kishore and Veerbhadra. I thank, and also my colleagues who are here for patient hearing. Any doubt, you can ask me later or during the surgery. It is over to you, sir. Manjunath sir.
It was a great it has great enhanced our understanding on laser equipment and instrumentation. Now, it is my privilege, now we will be moving to our inaugurational ceremony. It is my privilege to extend my warm welcome to our distinguished guest, our chief guest, Dr. T. Gangadhar Gaurati sir, our Honorable Director of BMCRC Ballari. So, Um, our guest of honor, Dr. Chidambaram Murthy, sir, he is in charge medical superintendent, MCH Bellary. I would like to request Dr. Parimala ma'am, in charge HOD, Department of Anesthesia. And I request our principal and head of the department, Dr. N. Junath sir, to please come in the diet. Yes, sir. Such. Yes, sir. I would like to introduce our esteemed operating faculties, Dr. N. Krishnamurthy sir. And I would like to invite our next faculties, Dr. Akshay Kutpaje sir. Sir. To shubharam and enlighten the gathering with positivity and grace, I am humbly inviting Dr. Sonali BN to come forward and present Ganesh Vandana.
अजं निर्विकल्पं निराकारमेकम् अजं निर्विकल्पं निराकारमेकं निरानन्दमानन्दमद्वैतपूर्णम् निरानन्दमानन्दमद्वैतपूर्णम् परं निर्गुणं निर्विशेषं निरीहं परं निर्गुणं निर्विशेषं निरीहं परब्रह्मरूपं गणेशं भजेमा परब्रह्मरूपं गणेशं भजेमा गुणातीतमानं चिदानन्दरूपं गुणातीतमानं चिदानन्दरूपं चिदाभासगं सर्वगं ज्ञानगम्यं मुनिध्येयमार्काशरूपं परेशं मुनिध्येयमार्काशरूपं परेशं परब्रह्मरूपं गणेशं भजेमा परब्रह्मरूपं गणेशं भजेमा गणेशं भजेमा गणेशं भजेमा. Thank you.
Thank you, Sonali, for the beautiful and soulful rendition of Ganesh Vandana. It has truly set the divine and auspicious tone for the proceeding. Now I would like to request our chief guest, our guest of honor, dignitaries and our faculties and our senior staff to kindly come forward and light the lamp and take the divine blessings for the successful event. Thank you, sir, ma'am. Now I would request our honorable chief guest, Dr. T. Gangadhar Gaurav, T. Sir, to kindly enlighten us with few words.
Good morning, all. Dignitaries on the dais, Principal, Ballari Medical College and Research Center, Dr. Manjunath, Dr. Parimala, Professor of Anesthesiology, and Dr. Krishnamurthy and Dr. Akshay from Bangalore, who have made all the way from Bangalore to here to be part of this laser-assisted microlaryngoscopy surgical workshop as a resource persons. Thank you, sir, for being here. And I congratulate the Department of ENT and for having conducted this workshop to keep pace with the change. Trending change, we need to keep updated every day. Otherwise, we will be lost in the ocean of knowledge. Department of Anesthesiology, all the participants who have made it for this workshop, and I urge all the postgraduates to make use of this opportunity, and which is useful in the day-to-day practice for you people in the future. Thank you, and have a nice day ahead.
Thank you, sir, for those inspiring and enlightening words. Now I request our guest of honor, Dr. Chithambaram, sir, to kindly address the gathering and share his valuable words.
Good morning, dignitaries on and off the dais, and all the other consultants who have come here. First of all, I would like to congratulate Department of ENT for conducting this workshop, which will be helpful for many of the postgraduates as well as to the practitioners also. So it will help in applying the recent things to the practice, and it will also help the PGs for upgrading their knowledge within our campus itself. So I also congratulate Anesthesia Department also for coordinating with ENT Department for conducting this. So congratulations to the Department of ENT headed by Manjunath sir and all the other staff members who have left a new step into this. So all the best wishes to all.
Thank you, sir, for your kind words. Now it's my privilege to invite Dr. Manjunath, sir, to grace the occasion with his words.
Good morning, everyone. Our beloved director, Dr. T. Gangadhar Gaurav, today's in charge medical superintendent, Dr. Chithambaram Murthy, Dr. Parimala madam, who is so enthusiastic to provide anesthesia for all the cases today. She has taken utmost care. Thank you very much, madam. On behalf of the department, I thank you, immensely thank you. And Dr. Krishnamurthy, the alumni of our institute, he has grown up like anything. We always feel proud whenever our own students overtake us. Really, it's a remarkable achievement in the field of ENT, especially the laryngology and otology. So he has made a very good name. Whenever I send the patients to him, he does a fantastic job. Apart from that, he gives maximum discount. When the patient is not affordable, I'll just ask him. Once I say that patient is not affordable that much, he will reduce the bill by 50%. I really appreciate your achievement, Krishna. And Dr. Akshay Kudpaje is very well known in the onco-surgery especially. He works at the HCG. And thank you very much, sir, on the Department of ENT, BMCRC. I immensely thank for coming all the way from Bangalore and demonstrating the surgeries. My special thanks to our beloved director. Whatever the instrument we have asked so far by stores and laser. Once laser was purchased a few years back, it went unused because of the lack of endotracheal tubes. So I made it a point this time when we purchased the 60 lakhs worth of a laser machine, it should be put into use. Whoever that comes, and we have got a very enthusiastic team in our department who is capable of managing all the surgeries, microlaryngeal surgeries. So this time we have made it a point to get the endotracheal tube, given us microdebrider, radio coagulation, a laser, good microscope, and a new set of endoscopes. All belongs to the prestigious companies. So thank you very much, sir. I have a small request. I take this opportunity that my request before I retire, I'm retiring on April 30th. So I want to see a new audiometry room. Kindly provide us the new audiometry rooms. So I'll take this opportunity to request you regarding this. So with that, I conclude my talk. Thank you very much. And all the postgraduate students, be attentive and try to make the best utilization of this workshop. Thank you very much.
Thank you, sir, for your valuable and insightful address. Now, thank you to all dignitaries.
I request Dr. Satyanand Rao sir to hand over the memento to our beloved director. I request Dr. Shankar to hand over the memento to Dr. Chidambar Murthy. With this, we conclude the formal inauguration ceremony. Next, we are going with a lecture by Dr. Akshay, followed by a lecture by Dr. Priya Singh of Anesthesia Department, and after that, we will go for the live surgeries. Thank you very much.
Continuing with the session of lectures, I would now like to invite Dr. Akshay Gudpache sir. Sir is an ENT trained head and neck surgical oncologist with extensive expertise in the comprehensive management of head and neck tumor. He is highly skilled in advanced procedure including ablation, reconstruction with free flaps, transoral laser surgery and robotic surgery in head and neck. His academic journey included MBBS from JSS Medical College, Mysore, followed by MS in ENT in GMC, NSCB, Madhya Pradesh, and further super specialization with MCH in head and neck surgical prestigious institutes of India and abroad, including Kidwai Memorial Institute of Oncology, Bangalore, Yonsei University Hospital, and Chris O'Brien Lifehouse Hospital, Sydney, and robotic certification and training at Severance Robot and MIS Center and Severance Hospital, Seoul, South Korea, adding to his vast surgical expertise. Currently serving as a senior consultant and head of the department.
Sir and his entire team at Ballari for giving us this opportunity. And we had a very good time yesterday as well, and we had a good sleep after that. In flight in various regions in head and neck. And specifically, I am going to talk about application on head and neck surgery. Of course, laser ablation, you tend to use it in multiple areas. But basic thing is, whenever you use any new tool, it should not harm or it should not compromise any outcomes. So in head and neck surgery, it can be used with the handheld attachment to perform oral cavity surgeries. So laser is a very precise cutting tool. However, it has inability to attain hemostasis, right? So as a result, it is not an ideal tool for cancers. So since I propagate myself as a laser surgeon, so I get a lot of T4 oral cavity cancer asking me to treat with laser. But the reality is, when you're dealing with oral cavity lesion, the application is limited to precancerous lesion, right? So when you have a laser, so you see this is the hand applicator, and you can see a knob here. So by pulling the knob, you can use it as a focused or a defocused beam. So obviously when you have a focused beam, it cuts very precisely. And as I mentioned, it is applicable, really the application of it is only in precancerous lesion. Very superficial lesion, because you go a layer deep, you have small millimeter blood vessel, you have to end up using a cautery. Most of the time, even when you're using a lesion like this, we have to have a bipolar handy to maintain hemostasis. In terms of precaution, in terms of anesthesia is pretty standard. So we use a endotracheal tube. We have to avoid one of the triad in the airway. So basically, fire happens only when there is all three components. That is, when you have fire is always there when you're performing surgery, that is laser. You should have a combustible material. You should have something dry which can catch up fire, and you should have oxygen. So the other fire which we cannot avoid, but the other two components, that is the oxygen, the anesthetic to keep the oxygen level low. Number two is we will not keep any combustible material. As we saw in the operation below, before, we had covered the entire face with wet mops, right? We use wet neuropathy to cover the cuff of the endotracheal tube. That's how the fire is too much of a hype in transoral laser surgery. But when you stick on to these basics, right? So we have very discussions that whether to use laser safe tube, all of those. But I mean, it's very difficult for me to talk on a panel where anesthetists are involved, because there is always a big debate on this. But we have evidence now with our own series of about 300 cases and our published case of about 70 cases, which are Dr. Dinesh and team from anesthesia have done that. When you stick on to these basics of avoiding that triad, the laser is just more of a hype. But provided we stick to our basic, and we should be able to know the checklist of how to manage the fire as well. So whenever there is a fire, how to deal about this and so on. So coming to the point again in oral cavity lesion, so this is how we perform this operation. When you with the handheld attachment with the focus beam, we cut it, and thereby the damage surrounding is very, very minimal. It takes a lot of time to do it, but sometimes in very select case, I think it makes a huge difference. When you have a very diffuse lesion involving the entire buccal mucosa, entire tongue, what we do is in a suspicious area, we remove and excise and send it for biopsy. Rest of the area, we move the knob so that the laser beam becomes defocused, just burn it everywhere, right? Just like burn it up in layer, like one shot burn everywhere, and then use a wet gauze piece and wipe that layer. So that entire condemned mucosa will just be removed, and then a new layer of epithelium grows over it, right? So what I mean is like this, like when you have an excise, this is we used with the laser, you can see this black spots in the bed. That is the bipolar cautery being used to control the small bleeders, right? But what is thing is the damage surrounding is very, very minimal. So we don't give antibiotics these patients post-op. Usually pain is managed with simple paracetamol. And we don't put a Ryle's tube, patient eat and drink the same day, but it will be on a liquid for about 2 weeks time. And good oral hygiene with normal salt water mouth rinses. And this is how it heals in 2 weeks time with good granulation developing. And this is how it heals at 2 months time, right? As a fiber, so the fiber, as sir mentioned previously, can be channeled through these applicators. It comes handy when you're dealing with transoral laser surgery of the vocal cord, especially in the anterior commissure, when the free beam you're not able to direct the lesion. So you may be able to excise every part, but that last bit, we will not get the angulation right to go right up to the thyroid perichondrium. Sometimes this angulated one to the fiber comes very handy. But this fiber put a lot of, it's very expensive, right? So this is nowadays the G3 laser and the newer laser comes with the multiple use laser fiber, but the one which was provided by Boston has use of only 5 times use, which costs about 2 lakhs rupees, right? So once you switch on this machine and plug this fiber, it gets counted as 1 use. So you need to bill the patient, obviously, you divide the 2 lakhs divided by 5 and this thing, and you have to judiciously use. But if you have a fiber, it really helps in navigating or to overcome those difficult anterior commissure lesions. So this was one case where, just to demonstrate the application of the fiber, where it really made a difference for this patient, is this patient had a subglottic stenosis, and the real application of this fiber is mainly for a short segment membranous stenosis. It's not for a long stenosis, but a short segmented membranous stenosis. You can channel it in a tubeless manner. You can either channel it through the working channel of the bronchoscope, and then use it as a cruciate incision, that Mercedes-Benz sign. Avoid incision in the posterior wall of the trachea because it's membranous. You may end up having a tracheoesophageal fistula. You plan your incision that you are not in the posterior, just cut only the membranous part and then do a balloon dilatation or simple endotracheal dilatation to get the exposure. Using longer applicators, you can use it for tonsillar, very again superficial lesions of the tonsil, leukoplakia, or in snoring surgeries also it can be used. And the cutting tool was a laser. This is just to show that, I mean, it can be used, but there are better tools to do tonsil and oropharyngeal surgeries than I think laser. But it's just for a completion I am just discussing. The real application of laser is in the larynx, right? The vocal cord is the very much area that none of the available tools kind of matches with the laser what we can achieve, right? And it can be used in multiple kind of areas or pathologies. You can use in benign and malignant glottic lesion. You can perform supraglottic lesion. So I will show in my video of laryngectomy with transoral laser surgery. But again, we need to slowly graduate from a very, very safe lesion of a benign lesion to begin with, a leukoplakia next, a free edge vocal cord lesion next, maybe a T1A lesion, well away from the anterior commissure. I think that's first year of any transoral laser service should go on these lines. Benign lesion, leukoplakia, free edge T1 vocal cord lesion, and then once you have a very clear understanding, the entire set is kind of gelled in this thing, because you can see that there are so many places where the things cannot go forward, right? It starts with getting the beam working at the first point. I think that's the most important, getting the attachment fixed. No, these are very, very fine instruments, and you need to handle that like a baby, like any other instrument. Because if you don't put the coupler properly, you don't align your coupler and the microscope properly, you will not have a beam. So initially when we started the operation today, we had some time to get the beam into the your area of operating field, right? So it's very, very important to understand that. So typically in our courses, what we do is, first step is to focus the beam, then try to use the beam on a veget, try to write on those dots so that you have an entire control of that laser beam and then move forward in your cases. So in addition to that, patient with bilateral ostomy for a bilateral ocal cord palsy, we can reverse the tracheostomy by doing a cordotomy and decannulate those patients, and slowly we can also embark on the case of a valvular cyst of the, and you need to choose your instrumentations right. No, the instrumentation is very important. So when you are doing a supraglottic or a base of tongue surgeries, Lindome scope is the very good scope to use, and for vocal cord it's the Dido scope. So I only use two scopes, Lindome for supraglottic base of tongue and Dido for the vocal cord work. So it's very important to use an endoscope and evaluate this lesion, take pictures to discuss with the family, make them understand, and then palpate the lesion and see. This was a very simple valvular cyst in the base of tongue, and you can see that we retain some amount of cuff of tissue so that you can grab it and not grab the cyst, so that you don't rupture the cyst, and then go around the lesion with a very which is focused, right? You can do almost all surgeries in the transoral way if they are feasible. You can see how we are gently using cut, then dissection, blunt dissection, grabbing, pulling, all of these maneuvers, so that you get around it, not damage it, and remove it entirety. Even though it's a benign lesion, we need to remove the entire cyst to prevent recurrences. It's very important to go around, and especially when you're doing supraglottic lesion or very extensive vocal cord lesion, you need to, since the laser beam cannot maintain hemostasis, you need to have a good suction monopolar forceps. And when you're doing supraglottic work, you need to have a bipolar laryngeal forceps as well as a laryngeal liga clip to ligate the superior laryngeal pedicle. Once it is excised, obviously you orient it. In a benign pathology, it doesn't make much of a difference, but whenever you're dealing with malignancy, you need to do it. And this bed can be left to heal on its own. We don't place Ryle's tube, we don't give antibiotics to these patients. They have eat and drink 6 hours after the operation. They have a very good recovery. They may have a bit of soreness for about 3 to 4 days, and then they are normal. It heals with a healthy slough formation. About a month's time, it's nicely mucosalized, and they do really well. When you're dealing a benign cyst like that, you need to preserve maximum mucosa. At the same time, we need to remove it in entirety. So you do a saline injection to kind of ascertain what's the depth, and also the saline infiltration helps us to perform this procedure to preserve maximum mucosa. That's the saline injection what we did. Then you palpate the lesion. So whenever you're palpating the lesion, suction scanner what I'm using. So this is a scanner blade. You can see that the scanner is said to have a lesser damage, slightly lesser damage compared to this one, which I try to preserve. So I work with a lot of laryngology colleagues, Dr. Krishnamurthy, Dr. Sanjay Subbiah. They always tell me that, Sanjay sir always tell me that to remove my oncological hat when I do the vocal cord work. But I tried the microsurgical cold steel technique in the oncology colleagues actually helps us improvise ourselves. So it gives a newer perspective, we improvise, and always collaboration kind of helps us to give a good outcomes. You can see each and every layer can be appreciated when you're doing in microscope with magnification. So you can see the epithelium here. Since it was a benign lesion, we try to preserve maximum mucosa as possible. What is important when you're doing vocal cord work is to preserve the subglottic mucosa as much as possible. That's where the vibration, vocal cord vibration happens, and the voice outcome is dependent on the subglottic mucosa. So wherever possible, as we are able to remove this lesion in entirety. Some interesting lesion, this was an amyloidosis of the posterior third of the vocal cord, and you can see that when you do this kind of an extensive like posterior third lesions, that's when there are vascularity. So you need to have a clear understanding of the endovascular anatomy. So we're all normally as like during our training, we all know the outside in anatomy. So you also have to understand the inside out anatomy, especially the vascularity, because this is an area where you're working in magnet, just exaggerating a little bit, but it's going to be a problem. But by having a good hemostasis available, so before we have one electric suction standby, right? We know that the technician which works with us is inside the OT and not outside the OT. right? Then we should not shout and it becomes a big mess. So this is an area where there is going to be bleeding and you need to have a monopolar suction cautery to maintain this thing. And you, as I told you, have a wet the gauze piece or the neuropathy to wipe all those granulation tissue and so on. Again, these are all done as day care surgeries, so they can go home 6 hours after the operation. This is one interesting case of a laryngocele. So you can see here, there is this submucosal swelling in the false vocal cord. Vocal cord area is completely mobile, right? And we did a CT scan to confirm that it was a internal laryngocele. That is, there was no extralaryngeal involvement, and it was limited into the paraglottic space and this region. So we, this is the laryngocele you can see here, and the vocal cord was completely fine. Discussed in the first surgery that really to see, to take pictures, because very important nowadays to show pictures to the patient. Otherwise, I mean, they will think that, okay, what have we done, right? So also for medical legal reasons, we need to take documentation, and that's the, you can see here, this is the thyroid cartilage, very extensive resection. This is the voice of the case of and this was the NBI being done. The implementation of laryngoscopes is very important. So we use the small bore laryngoscope in this case. Again, here the most important thing is a good anesthesia team. A good relaxation is the most important part in transoral laser surgery. And you can see this narrow bore laryngoscope. One of the drawback of this is a Steiner narrow bore laryngoscope. You can also use a Hollinger slimline laryngoscope in these cases with the standard suspension, and that is what the visualization was. And this was referred, one of our ENT colleagues in Bangalore who tried this and not difficulty, and then he referred it to us, but luckily we were able to excise it. This also could have been done with a flexible bronchoscope or flexible laryngoscope with a working channel, and also could have been done, but then we did this using a laser. This is another interesting case of a supraglottic stenosis, where again a simple cruciate incision on either side helped the patient. Otherwise, the patient had a ball wall. On every inspiration, this was sucking in, and then this patient was from Bangladesh, had immediate relief. I don't have the post-op or post-op picture, but this patient was doing fine. When you have a laryngeal papillomatosis, I think it's not just laser. What you need to do is use a laryngeal debrider. Debride the tissue, because when you're doing laryngeal papillomatosis, it is limited only to the superficial layer. You don't have to do extensive excisions, right? What you want to do is completely debulk to the surface and then use a defocus beam and use a laser for the surface, because these patients are going to recur, and every antiviral injection does help. And when there is, this was case of a bilateral oncologist helped me. So how do you decide what type of cordotomy has to be done? So when you're doing a bilateral local cord palsy cordotomy, what you need to do is using do extensive cutting of the arytenoid process and so on. So what you need to do is do a vertical cut onto the vocal process of the arytenoid right up perichondrium, right? Once you do that, what happens is when it heals, the vocal process of the arytenoid will open up like a door, and thereby your arytenoid is fixed. Then you have to do an extensive resection of the posterior third of the vocal cord and the vocal process of the arytenoid. Okay, you may do a 100% resection, which on healing will be giving you a 30%, roughly 20 to 30% of a gap. So if it's a fixed arytenoid, we do extensive cutting of the vocal process and the tissue of the vocal cord. And when you have a mobile vocal cord, you just cut the membranous vocal cord from the vocal process of the arytenoid right up to the thyroid, up to the cricoid, preserving the perichondrium. Thereby you get a very good outcomes. So nowadays we see a lot of chemoradiations being done for larynx with the idea of organ preservation, but hardly the organ gets preserved. That's the reality in most of the situations. There are about good number of cases where larynx can be preserved, but most often in the attempt of organ preservation, we end up managing a lot of complicated situation like this. This was not a laryngeal cancer being treated. This was a tonsillar cancer treated with chemoradiation. Patient had a very bad laryngeal edema, and the patient was tracheostomized, and patient had I think patient was swallowing through the mouth liquids with the PEG tube, I guess. So this patient was disease free 2 years, but this was a situation. So what we did is, we used laser to make small holes into the supraglottis, arytenoid, that area, and we cut a little bit of epiglottis as well. And there was a lot of laryngeal edema as well. The neck was swollen. So we did the family did a lot of massage. And then by about 6 months' time, we were able to decannulate these patients. This patient needed 3 laser procedures in different intervals. And finally, now the patient is disease-free, is eating and these things. This is one of the rare things where we used our experience with laser to make the patient decannulate for a laryngeal edema. The real application of transoral laser surgery is in early glottic cancer. As you know, early glottic cancer is a very, very favorable cancer with an excellent prognosis. The good thing is anatomically it has very sparse lymphatics. All sites in the head and neck, whether it's a T1 tongue cancer or a T half tongue cancer, you need to do a neck dissection. But vocal cord cancer is in only one site where it's an early vocal cord cancer. You don't have to address the neck. This opens up an opportunity to just treat these patients transorally without needing to address the neck. And anatomically also it has vascularity is very, very limited. You have to have an understanding. There is a very small blood vessel in the anterior commissure, posterior commissure area. You need to have to understand that vascularity. When you look at the free edge of the vocal cord, it's almost avascular, except for the anterior commissure and posterior cancer. As a result, in early glottic cancer, only the primary needs to be treated and not the neck. So the vocal cord cancer as such is not one entity. It can come in different, and you would have seen a T1 is a free edge vocal cord is different from a lesion which goes to the anterior commissure, which is different from the lesion which is going to the anterior paraglottic. So when you look at the radiation oncologists, they don't see the patient, they don't scope the patient, they have no idea of what they're treating. They just treat the scans, which is hardly visible. When you T1 vocal cord, when you see a scan, it's hardly visible. I don't know how they plan without having an understanding of an endoscopy, right? So no doubt it has an excellent outcome. And when you look at the outcomes, radiotherapy, transoral laser surgery, open conservative surgery, all have equivalent oncological outcomes. In fact, among the 3, open conservative laryngeal surgery has the best oncological outcome. There is no comparison. It is about 30% ahead of both laser surgery as well as radiotherapy. But there are problems with the open conservative laryngeal surgery, that the recovery is delayed, patient has to go through post-op rehab, the voice may be slightly compromised. More importantly, we don't have the skills to perform the open conservative laryngeal surgery. But because of better understanding with transoral laser surgery, majority of those lesions which can be treated with open conservatively now can be managed with transoral laser surgery. But definitely there is definitely space for better understanding of open conservative laryngeal surgery. So it's not a competition between radiotherapy or transoral laser surgery, but it's what is best to the patient. So when you have to decide between radiotherapy and transoral laser surgery, the first and the most important thing is oncological control. That patient has to survive when you do a treatment, and it has to be treated with only single modality, either radiotherapy or transoral laser surgery. When you look at outcomes, when you look at evidence, transoral laser surgery is equivalent to radiotherapy based on evidence. There is no randomized trial, but long prospective trial, long retrospective data from India and abroad shows that there is no compromise in cancer control between laser or radiotherapy. So the next important determinant to decide between laser and radiotherapy is the function preservation. So function, people talk only about voice. It's not only about voice, but also it's important is long term, how many of them have an intact larynx able to eat and drink through the mouth. Voice is important, but also we have to look at long term larynx preservation, which is functional, not with a tracheostomy, not with a PEG, but a functional larynx preservation. And most important situation in our setting is the cost of treatment. So laser is a single day treatment or maximum 1 day stay in the hospital, compared to radiotherapy, which is a 6 weeks or a 4 weeks treatment. Not only the cost of treatment, there are indirect costs involved. If a patient from Ballari has to undergo radiation, I mean there is a radiation facility in Ballari itself, the family has to take off from work, the patient has to take off from work, he has to put a fuel to his car or a bike, he has to have some coffee, tea, something. All those costs have to be factored in decision making as well. So radiotherapy has to be discussed, so laser surgery has to be discussed as a treatment option in the patients with vocal cord cancers. So there is a classification for standardization of the defect to compare outcomes. This is the European Laryngology Society. Europe is one country where they have enormous expertise with transoral laser surgery, open conservative laryngeal surgery. In fact, Professor Steiner from Germany is the one who kind of popularized and got this technique to be accepted world over when sitting in a small village in Germany, right? And then Professor Peretti, Piazza, and so on. So there is, to get that similar standardization, they've come up with a classification of the cordectomy, which all postgraduates should be aware of. Type 1 to type 6 is the extent of which you can look it up in your textbooks. So in addition to the oncological control, organ preservation and cost, since laser is a cutting tool, we get tissue for analysis, histopathological analysis. For a patient, they know that the cancer is removed out of the body and it's cured. It's not just burnt and in a suspicion you do a scan, there is a bit of edema, you know, don't know whether the patient is, cancer is come back, not come back. Even though you have tools like NBI and so on, when you give radiation, that has some fallacies, you know, in identifying and differentiating these problems. And more importantly, nowadays you have beautiful endoscopy system across all clinics. Small clinics has a beautiful Hopkins scope. You can easily follow up these lesions. You don't need PET scan. So most of our patients come and ask me, sir, PET scan madila madbeka, right? Simple Hopkins evaluation, we can really kind of, there's no need to do PET scan and those sort of situation. And more importantly, since this patient can have second cancer, we can keep radiotherapy as a standby. I'm not telling radiotherapy is not important tool. It's a very, very important tool. But once you exhaust radiotherapy, if the patient comes with a second cancer, you can obviously cannot give radiotherapy, or you have complications, so many folds increase with radiotherapy. So obviously when we decide, we look at NCCN guidelines for treatment, and in NCCN guidelines for vocal cord cancer, NCCN guidelines clearly puts transoral laser surgery equivalent to that of radiotherapy, right? So there is no debate. There is no debate that laser surgery is inferior to radiotherapy. Both are equivalent. We need to decide what is best to the patients. So this is one case. This was a professor of one of the medical colleges in Bangalore who presented with vocal cord lesion, and this is a case, as sir mentioned, I didn't do a biopsy in this case. So straight away we counseled the patient and went ahead with the transoral excision biopsy. As I just mentioned, I do a type 2 cordectomy for all my patients. So this is the anterior commissure, so that's the thyroarytenoid muscle. The first cut, what we do is the anterior commissure cut. That's when, because once we cut the posterior, the anterior commissure will go, it will be difficult to visualize. So do the anterior commissure, then come around, get margins, send it for histopathology. You can see this is a thyroarytenoid muscle, vocal process to the anterior commissure, and this thing. This is how it heals. That's the voice of the patient at 6 months. You can see there is a bit of phonatory gap in the thing, so the small phonatory gap here, but that with good rehab, you can overcome that. So this is a very, very common situation. Patient with a vocal cord lesion underwent MLS biopsy, and turned out to be a cancer, right? This is patient straight away get referred for radiotherapy. As we discussed in the morning, 30% don't have tumor in this. No, this is not, I'm not just making up. You look at the evidence of open conservative laryngeal surgery, laser surgery being done on large data. 30% of patients don't have tumor. In fact, this patient didn't have tumor, right? Otherwise, this patient would have undergone radiotherapy with no cancer, right? So this is a lesion straight away. It's a case of an excision biopsy. And so this was, they came to us. You can see the small granulation tissue. In this situation, it's very important to call the previous ENT surgeon, get the endoscopy picture if you don't have it, and then discuss with them to get a kind of picture where the exact lesion was. And that's the excision being done, a type 2 cordectomy being done with a free beam. And that's how it has healed at 1 year time.
ಬೆಂಗಳೂರು ನಮ್ಮ ರಾಜ್ಯದ ದೊಡ್ಡ ಊರು ಈ ಊರನ್ನು ನಮ್ಮ ರಾಜ್ಯದ ಬೊಂಬಾಯಿ ಎನ್ನುವರು.
So that's the outcome of a type 2 cordectomy, right? Slightly more extensive lesions. This is slightly more extensive. These are the patients, obviously we look at laryngeal exposure, if it all ticks, right? So here, when you see this lesion, it looks very subglottic, right? So contraindication of doing a transoral laser surgery is when there is subglottic extension, when there is posterior paraglottic extension. But on examination, when we did an endoscopic evaluation, you see that it's a peduncle lesion, right? So this was an elderly gentleman, I think he was about 75, 80 years old, right? So we took this counseling and then we went ahead with a very extensive excision. So you can see this cricoid cartilage here, a bit of charring for the controlling of bleeding in this area. These patients are going to have a crappy voice, which obviously have to be counseled when they do. And this will definitely come for a second look at 3 months' time, okay? And that's the second look. You could see the granulation tissue here and the biopsy here was negative. So this patient we didn't give radiotherapy for this patient. This patient was from Kannur, was referred from Kerala, and that's how it has healed. This was the 3 months endoscopy, frozen, no malignancy at 3 months. And that was the voice of the patient. Not very great, but this patient came to Bangalore, stayed in the Bangalore for 2 days, and he was back in Kannur the fourth day, the third or fourth day. And then the regular follow-up was done by the local ENT doctor in Kannur. And then 3 months or about a year time, they come to us and just have a see. Every time they do an endoscopy, they share the endoscopy, and that's how we keep under follow-up. There was slightly more extensive lesion of a varicose lesion involving the entire length of the vocal cord. So when you have a larger lesion, it is oncologically safe to do a transtumoral resection. So normally in cancer, we don't go into the tumor, we go around it with a cuff of normal tissue. But in vocal cord, in the vocal cord lesion, it is oncologically safe to do a transtumoral resection. It will also help us to ascertain the depth of the lesion. So you can see here that we did a transtumoral resection. This is the thyroarytenoid muscle. We did the anterior part of the resection first, guided with frozen section. We don't need frozen section for superficial margin, but what is important is the deep margin where we definitely rely on frozen section to get this thing. And once we do the anterior part, we push the endotracheal tube forwards, suspend the laryngoscope and do this. This is sometimes the endotracheal tube slips down and causes a lot of trouble, and these are the situations where nowadays we use a tubeless anesthesia, the Thrive and jet ventilation. When we have a posterior lesions, we would go for a tubeless or an apneic technique to perform the posterior third of the lesions. Or when you have a bulky lesion, we will start with Thrive, finish off the difficult part, and then go for a tube incision. That was his outcome at 3 months' time. So it's hardly, you need to look at the operating notes to see which side we have operated. So the beauty is the tissue heals so well, provided you have a focused beam, you stick to all your basics, right? So most of the time when I see my patients at 6 months, 1 year, I don't know which side I have operated. I have to see the operating notes to see which side I have operated. So it's such a beautifully it heals. When a lesion in the anterior commissure, again, the voice is not going to be so great, like compared to a free edge vocal cord up to a type 3 cordectomy. So the voice is going to be compromised. This is where you have to have a discussion with the patient, understand what their outcome, what is their expectations, whether they want a short treatment or whether they want voice as the priority. So this is one elderly lady, again about 80-year-old, 75, 80-year-old patient. You can see a very extensive resection. But again, when you do such an extensive resection as well, you see how beautifully it heals again, right? There is going to be definitely a synechy in the anterior commissure. This is in the endoscopy at about 2 weeks' time. You can see healthy slough. But these patients eat and drink the same day. They have no aspiration. There is no issue. Only when you disturb the arytenoid, that's when the aspiration happens, right? Arytenoid means interarytenoid area, not the vocal process arytenoid, interarytenoid, extensive body resection. That's where aspiration happens. And see, that's the voice of the patient. Good conversational voice, they are comfortable. I asked whether we need to release the synechy. She hardly comes for follow-up as well, right? But she's doing fine. So the expertise gained from this, we have also started doing salvage surgeries. Okay, salvage surgery. This was a case of vocal cord T1 vocal cord treated with radiotherapy and had a residual or a recurrence at about 2 years time. So this was one referred from Ahmedabad. One of my head and neck friend had referred this case. You can see this is the examination under anesthesia. Lesion in the anterior third vocal cord. So this is the scope what we prefer, DIDO. I think this is the one scope, sir, you have to procure this for when you're doing transoral laser surgery, DIDO and a suction fume. So we had a lot of trouble for the suction. We could have seen that in the first case. So you need to have a simple suction. You can have the Storrs laryngoscope, you can have a Kalelkar suction, like we can do the Indian Jugaad and make it better, right? So when you have a larger lesions, we don't shy away from doing a false cord resections, right? Many of my laryngology friends tell, don't disturb the false vocal cord, but I don't see any difference in functional outcomes. So my threshold for resection of false cord is very, very limited, and I closely follow Professor Peretti, Professor Piazza, Carsten, my mentor. So the Europeans are a proponent, even in the T1A vocal cord, they would excise the entire false cord, and I am also starting to doing that now, and there is no difference in outcomes. So we wouldn't compromise or we wouldn't shy away from resecting the false cord, especially in the anterior part of the anterior third. Otherwise, we won't get the third dimension resection in or go up till the thyroid perichondrium for resection. So this is the granulation at 3 months time. So that's normal. People get scared that what is this, cancer has come back. But if it is persisting beyond 3 months, we would take them back for a second look and then excise and send it for histopathology. Most of the time, it's only granulation tissue. So this is the patient from Ahmedabad, right? So salvage laser surgery for an vocal cord being done. Slightly more challenging case. So this patient was a case of CA supraglottis treated with chemoradiation, had a residual disease. So when you look at that lesion, this should go for a total laryngectomy, total pharyngectomy, free flap situations, right? So we did a PET scan, we did an MRI, thoroughly evaluated the patient, and then took this patient with, of course, a consent for open surgery if at all we are not able to do negative margin. You can see this is a lesion on endoscopic evaluation. The true vocal cord is completely free. That's how the endoscopic evaluation is very important. You can see this paraglottic extension. And this is the palpation of the lesion. So this is a lindoscope we are using. The lindoscope has about 5 centimeter of the working space on the proximal end. So you can use Liga clips, you can also suture very easily, endolaryngeal sutures and so on. In this case, we used a nasotracheal intubation, but my friends told oral intubation would have been better in this case later. You can see we have done a transoral hemilaryngectomy. This is a pre-epiglottic space, this is a paraglottic space. You can see these 2 clips here. These are the laryngeal Liga clips, normal Liga clips, white Liga clips, used with a laryngeal clip applicator used to clip the superior laryngeal pedicle, right? And this is the hyoid bone here. This is the hyoid bone, this is the pre-epiglottics, this is the thyroid cartilage, and this is the arytenoid. So it's nothing but a hemilaryngectomy done transorally, right? But when you do this extensive, obviously this is guided with frozen, so we make sure that we have got the deep margin positive. By margin, we are not expecting a 1 centimeter margin here. Even about 2 millimeter margin here is good enough to keep under close follow-up. Because the hypothetical 5 mm margin is not based on any evidence. It's based on some mathematical calculation. So certain sites, tongue is going to behave bad, we take more margin. But there is no real evidence for margin. Because when you're doing transoral robotic surgery, we do about 2-3 mm margin. Because each structure is anatomically different. Tonsil is a layered structure, tongue is a muscular structure. So that's how you have to differentiate and guide your margins. You can see this, it's like pre-op, intra-op picture, like an extensive resection. When you do this kind of very extensive resection, obviously the patient is going to have significant issue eating, drinking, and also breathing. This is the endoscopy, I think about 3-4 weeks after pooling, no aspiration. Again, the rehab or swallowing specialist work very, very closely with this patient with initially positive maneuvers, helping her guide, helping him 3-4 weeks time. So there is bit of penetration, no significant pooling, all comfortable. So working closely with the rehab specialist, very, very important. The swallowing specialist forms a very, very important part of our treatment team. whether it's radiation, whether it's a tongue surgery, any head and neck surgery, the swallowing specialist gets involved before the starting of the treatment. So it's always important to involve get the confidence of the family as well. Otherwise, they think only surgeon does the job, but there are a lot of other people around who help in the recovery of these patients, right? And preserving the epiglottis is very important. It forms a significant help in the rehabilitation process. It, as a first tier mechanism, it covers the larynx like a lid and thereby help in the recovery. 40 days we cap the tracheostomy and remove the tracheostomy tube. Suddenly the swallowing just improves like that once we remove the tracheostomy, because the laryngeal elevation happens better, all the rehab process gets speeded up. 40 days outcome of voice, still we kept his peg tube there but continued to swallow with little quantity of liquids and semi-solid food. And this is the endoscopy at 2 months. See how beautifully it has healed. Such an extensive resection in a salvage situation, post-radiotherapy. Vascularity is bad, everything is bad, right? But still the outcomes. But there should be young patient, good mouth opening, good exposure, all good disease to remove as well.
ಹೊಟ್ಟೆಗೆ ಟ್ಯೂಬ್ ಹಾಕಿ ಹೊಟ್ಟೆ ಮೂಲಕ ಇಲ್ಲಿ ಟ್ಯೂಬ್ ಮೂಲಕ ನಮಗೆ ನೀರು ಆಮೇಲೆ ಲಿಕ್ವಿಡ್ ಐಟಮ್ ಏನು ಬೇಕು ಹೊಟ್ಟೆಗೆ ಸಂಬಂಧಪಟ್ಟಂಗೆ ಎಲ್ಲ ಇಲ್ಲಿ ಪೈಪಲ್ಲೇ ಕೊಡ್ತಾ ಇದೆ. ಈಗ ಒಂದು ತಿಂಗಳಾದ್ಮೇಲೆ ಈಗ ತೆಗೆದಾದ್ಮೇಲೆ ಈಗ ಚೆನ್ನಾಗಿ ಊಟ ಮಾಡ್ತಾ ಇದ್ದೀವಿ, ಎಲ್ಲ ಮಾತಾಡ್ಬೋದು, ಏನು ತೊಂದರೆ ಇಲ್ಲ, ಚೆನ್ನಾಗಿ.
That's a 2-month endoscopy. This is almost 3 years now. He is disease free. He is absolutely fine. So nothing to worry. So, but this is very important. When not to do transoral laser surgery as an upfront treatment, right? So this paper by Professor Peretti beautifully describes the entire indications and which not to do. But as a beginner, we need to do T1A, benign lesion, leukoplakia, and once you gained experience, you can straightly go. But which is a strict no is obviously inadequate laryngeal exposure you cannot remove, so you wouldn't go. You do a biopsy, come out, and then send the patient for radiotherapy. When there is a posterior paraglottic, when the lesion is in the posterior third of the vocal cord, then those are, if it's come up till the vocal process of the arytenoid, I wouldn't do a laser surgery even now, because then I can technically resect, but then you need to address lymph nodes. Patient is going to have significant poor voice, swallowing, all issues will come. So that's a strict no. When there is a bulky anterior commissure with subglottic extension, again we can technically sometimes, but there is a better technique of radiotherapy to deal with that situation. So those are the definite no cases. Even though good laryngeal exposure, when there is a posterior third infiltration, vocal cord impaired mobility, then we would do a biopsy and send them for non-surgical organ preservation. So decisions are not only guided by disease factors but also patient factors. What the patient wants. Patient wants a quick 1 day or 2 day treatment, or whether he wants to undergo a longer duration once the disease factor. And of course the team, the MDT, because when we started laser surgery at our hospital, so the radiation oncologist used to tell us Akshay is doing unethical treatment for patients. So what is important is to gain confidence on them. How do we gain it is take the videos, put it in the tumor board, take the follow-up videos, show it to them, right? Then slowly what they do is, whenever they have a friend and relative, they would refer the patient for laser surgery, right? They would treat still other patients with radiotherapy, but it was, if it's his father, it's uncle, someone, sister, they still send it for transoral laser surgery. My own close friend, classmates, we would have debates, but unfortunately when his dad had a vocal cord cancer, he referred for laser surgery. He came to the operating theater, he saw, luckily the dad is doing fine, and I have gained his confidence as well. So finally, to conclude, for a carcinoma in situ, a T1A, there is no debate. No, it's laser surgery is the better treatment option. For a T1B, that is when the lesion goes to the anterior commissure, the voice is going to be slightly subnormal compared to that of radiotherapy. You need to have a discussion about the voice expectation. How I do is, I have a recorded audio of patients of various type of cordectomy. I just play them this, almost this is how the voice may look, may look like, and then they make that decision. When there is a bulky anterior commissure extension, subglottic extension, I do a biopsy. Technically, I may be able to do it, but I have, by experience, found that that's not better. And after reading the articles, I'm more sure that it's not good. So I do a biopsy and send them for radiotherapy. T2 lesion, supraglottic, again, TLM is an option. We discuss with the patient, share them the voice outcome, and then make a decision. So what is important is transoral laser surgery has to be offered to the patients with early glottic cancer as one of the treatment like radiotherapy, equivalent treatment option. To gain the confidence of the team, so we need to get that patients, all our patients to the MDT, show them and audit our own cases, not only to prove to themselves but also to for ourselves that we are doing right. And it should be audited. All our cases have to be audited and discussed. So thank you. Thanks for the opportunity. So any questions we can discuss. Yeah, I think so. The cobbletter is a very good tool, but it is for a vocal cord. I think it's a bit of a more of a damaging tool. See, the thing is, when you're doing a destructive procedure, like if you're doing a Kashima operation, laser cordotomy, so I think that's a very fantastic tool. When you're doing base of tongue surgeries, when you're doing supraglottic, that can be a handy tool for base of tongue, lateral pharyngeal wall, that area. But vocal cord, I think, is best treated with CO2. Other areas, probably transorally is okay. So I'm not a big fan of cobbletter for vocal cord. It definitely has application for base of soft tissue, I think, because of its ability to coagulate. I think it speeds up, makes things very easy. With laser, it becomes a pain, no? If you don't have any of these instruments. Yeah.
Your experience with any other lasers?
So sometimes, since the fiber is very expensive, sometimes we borrow lasers from urology, right? So I had one patient who had a very difficult laryngoscope. I think it's seen by almost many of the people in Bangalore. I have done about 2 times. I have done laser surgery for that patient as well. So in that case, because of the difficult laryngeal exposure, the anterior part was not. I was not able to focus the beam. So that's where I used the urology Holium, I think, thorium, with some urology laser, again through the fiber, and it worked fine for me. KTP, I have no experience. I think Krishnamurthy sir has experience on that, but it's almost similar to that, but it has better hemostatic. But there is a lot of charring as well. So then it's not the good, the healing. Yeah, healing, granulation, all those will affect it. But since out of compulsion, because so KTP laser, any experience?
No, sir. KTP, I don't have any experience. I have not used it. Diode laser we have used. Diode laser I have used. Diode laser, especially larynx, no, only if at all bilateral vocal cord palsy for
procedures. Yeah.
contact laser.
And hemorrhagic, maybe hemorrhagic polyp, they do it as daycare also. You can do with the working channel bronchoscope.
And second thing, a diode laser where it will be helpful andre when you are doing a obstructive sleep apnea for UP3 laser, that is very good. Yeah, it's a very good diode laser is very good tool. ಕಡಿಮೆ ಇರುತ್ತೆ and precisely you can cut the normal tissue and do a plasty. So
Carbon dioxide takes out so much time to do. It's like slow, cuts very, very slow. The fiber also cuts very, very.
very
No,
precise.
but damage is less.
Yeah, damage is less.
So even for subglottic stenosis, you can use a free beam and do if it's above maybe about 3 centimeter, you can do with free beam. So you use the laryngoscope to retract the vocal cord and then do the. So we have done one.
Thank you, sir. It has greatly enhanced our understanding of laser application in head and neck surgeries. Now, moving on to next lecture, I invite Dr. Priya Singh ma'am. Ma'am is a senior resident at BMCRC Ballari at skilled in general surgery.
Good morning everyone, I'm Dr. Priya Singh. Today I'm going to present about anesthetic considerations in laser surgery. Laser, it is light amplification by simulated emission of radiation. The laser beam is a source of energy that can be focused with high intensity and is capable of vaporizing tissues and photocoagulating, replacing the scalpel at the microscopic level. The indications of lasers are mostly used in ENT procedures, which are of vocal cords, nodules, polypology, urology, and neurosurgical procedures. Tissue damage, drape fire, endotracheal tube fire, ion fire, and the explosion. So whenever lasers are used, eye protection is important, and these are the various goggles and eye gear which can be used for various types of lasers. Pre-anesthetic evaluation of laser surgery in the airway. In this, the prior thing is detailed history and physical examination should determine the degree and existing airway obstruction along with the ease of breathing and any conditions like presence of hoarseness, stridor and hemoptysis. And there should be a clear idea of about location, size, extent of. In older and debilitated patients, very thorough. When it comes to obesity and history of acid reflux, it should be noted and as it causes the risk of aspiration. Anesthesia technique should be based on the potential threat to the airway and be prepared with rescue measures including tracheostomy in the presence of airway emergency. Before all this, there should be a clear discussion of plan between the anesthesiologist and the surgeon. Most important factor would be to predict the ease of ventilation with face mask and ease of intubation with direct laryngoscopy. In any case, if any of the airway is compromised prior to induction, it is better to secure the airway. And various airway gadgets are also needed before going to the procedure, and these are the list of gadgets which should be kept ready along with the difficult airway cart. And pre-medication. First, we use sedatives to pre-medicate the patient. These sedatives will relieve the anxiety in the patient. And if the patient's airway is compromised, do not use any sedatives without a proper backup of oxygen and suction. So the medications which are used are glycopyrrolate, fentanyl, midazolam, ondansetron, and dexmedetomidine. And induction of anesthesia, before inducing any case, standard ASA monitors are compulsory, which are pulse oximeter, BP, ECG. And in the absence of airway obstruction, intravenous or inhalational anesthesia technique can be used. In patient with compromised airway, an experienced anesthetist and surgeon should plan the technique to secure the airway based on the result of video laryngoscopy, which should be done prior to the procedure. And in awake patients, fiber optic is best when in case of obstructions. Next, choose the appropriate technique and device as per the resources, and smallest acceptable size of endotracheal tube is used, which will minimize the and give good exposure to the surgical field also. And the cuff here is filled with normal saline, not that the air, because air can cause combustion when laser is used. And FiO2 is also reduced and nitrous is avoided, and a spare endotracheal tube should always be kept ready. And there are two types of ventilation. Two types of ventilation techniques are used. One is the intubating technique and other is the non-intubating technique. Non-intubating technique, sir has already told. And when it comes to the types, one is intermittent apnea technique. In this, the patient is intubated and extubated intermittently, and after removal of endotracheal tube, an apneic period is allowed, and the duration is guided with pulse oximeter. And TIVA is used to maintain the anesthesia. Advantage is it gives you good visibility of the field and it is safe from laser, but the disadvantage is there should be multiple intubations and extubations which might cause trauma, and surgical time is also limited, aspiration risk is there, and there won't be a consistent depth of anesthesia. When it comes to spontaneous ventilation, in this the patient is anesthetized, but the patient will be breathing spontaneously. Oxygen enriched gas is given to the patient. This also gives a good visualization and vocal cord function also. The disadvantages are same. The airway is not secured, so there will be risk of aspirations, and depth is not consistent and can be used only for shorter duration procedures. Airway, through this continuous oxygen supply is given to the patient. Disadvantage is also same. It also is not a secured airway way. It can cause is delivered into the upper airway. High frequency ventilation delivers very small tidal volumes at a very high respiratory rate. So, an injector is connected to the gas supply and it insulfates the gaseous mixture into the trachea. But it requires a patent airway. Whenever there is smaller airway obstruction also, the air won't come out and there will be air trapping which will lead to pneumothorax. And a specialized equipment is needed. The personnel who should be operating this high flow machine should be needed. TIVA technique and blood gas monitoring is repeatedly needed. And when it comes to intubation technique, there should be a preparation of conventional endotracheal tubes because the tubes which we use are polyvinyl chloride tubes. They are more prone to combustion. So to prepare the tube, we'll wrap the tube with an aluminum foil and on top of it one more layer of a white colored tape. And whenever using your tube, FiO2 should be reduced and the cuff should be filled with saline mixed with a dye, so that if there is any leak or any breakage to the cuff, the dye will seep out and you will get to know that your tube is damaged. And main important thing is muscle relaxation. When the surgeon is operating over there and you can't let the patient to buck and you can't let the patient to be in a lighter plane. This is how a normal endotracheal tube is wrapped using aluminum foil. And the covering should be from the tip of the tube to the cuff, not over the cuff, because if you close the cuff, you cannot inflate the cuff. There are special tubes. This is one of the tubes, Bivona foam cuff tube. This is the aluminum and silicon rubber tube with a self-inflating sponge cuff. This is non-flammable, and whenever the external source is damaged also, the cuff can protect your airway. The only problem what we have is, it is very difficult to deflate the cuff and pull out the tube if there is any mishap in the surgery. Next is laser flex tube. These are the stainless steel metal tubes with a Murphy's eye. Some come with cuff, some come with no cuff. No cuff tubes can be used for pediatric cases. When it comes to cuff tubes, you should fill this with dye. And there are two cuffs, the proximal cuff and distal cuff. If even one cuff is damaged, the other one will protect your airway. The disadvantage is that the metal can reflect the laser the cuff model consists of materials which are flammable, and the metal tubes are thick walled, and the double cuff takes more time to inflate and deflate. This is the laser shield tube. This comes with already a silicon wrapped rubber tube with aluminum wrapped over a Teflon, and the pilot balloon has methylene blue in that. Advantage is wrapping prevents the laser beam from igniting the tube. Teflon coating is smoother, less traumatic than most manually wrapped tubes. But the problem is, if the tape is dislodged, it can occlude the airway. And the tubes cannot be wrapped below the cuff. If the surgical area is below the vocal cords, then this tube is not of any use. A ventilator. Advantages is that metal is not flammable, but the disadvantage, it has hinges and joints, so that it will lead to leak. It might cause combustion or damage to your tissues. This is the triad, and these are the sources of ignition: electrocautery, laser, and endotracheal tube. Very important thing to be noted in laser surgeries. If the tube catches fire, it is like a blowtorch fire. First, when the oxygen going through that, it will definitely seep in, and it comes like a blowtorch over here, this way. And it will burn your entire airway. So in such cases, if your airway is caught in fire, the first thing which you are supposed to do is stop ventilation and turn off the oxygen, and disconnect the circuit and pull out the endotracheal tube. And then extinguish the fire and flood the surgical field with saline or fluid. For that, you have to keep a bucket of water or some NS as a backup in your airway trolley. And next, assess the airway using fiber optic bronchoscope, and whatever the combusted materials are in your airway, you have to just remove them. And first thing, disconnect the circuit, extinguish the fire with water and saline, continue IV anesthetic agent, mask ventilate the patient with 100% oxygen, perform direct laryngoscopy or bronchoscopy to assess the damage and remove debris. Bronchial lavage also can be done, and re-establish and assess oropharynx and face. Thank you.
Thank you, Dr. Priya, for an academically enriching lecture. Kindly settle down. Now we'll proceed to the next surgical session of our live surgical demonstration. We'll now move on to OT number 10 for our next case. Thank you.
1 minute, 1 minute. So once you introduce the laryngoscope, you have to check for the position of the cuff. Ideally, it should be 2 centimeter below the vocal cords for all transoral microlaryngeal surgeries. But here you can see it is
full deflate.
just above the vocal
No,
cord.
sir.
Again, we are
New syringe.
repositioning it.
Take a new syringe, empty syringe.
ಇದು ಆನ್ ಮಾಡಿ ಅಲ್ಲ ಆನ್ ಮಾಡಿ 1 minute ಆನ್ ಮಾಡು. Since it was above the vocal cord, we are repositioning it again, the ET tube.
It will stick to your gloves.
Yeah, it's deflated. Suction couldn't. Let it be there so that I can re-enter. Push ಮಾಡಿ 1 minute. Suction ಕೊಡಿ. Don't pull it, madam. Don't pull it. It will come out. 1 minute. You have to hold it over. Now you remove.
Disconnect ಮಾಡಿ.
Okay. 1 minute. 1 ನಿಮಿಷ. ಇನ್ನು ಸ್ವಲ್ಪ ಕೆಳಗಡೆ ಸ್ವಲ್ಪ ಇನ್ನು ಸ್ವಲ್ಪ ಕೆಳಗಡೆ ಇನ್ನು ಸ್ವಲ್ಪ ಪುಷ್ ಮಾಡಿ. ನಾವು ಇಟ್ಸ್ ಫಸ್ಟ್ ಇದು ಫಿಕ್ಸ್ ಮಾಡಿಬಿಡಿ. ಇನ್ಫ್ಲೇಟ್ ಮಾಡಿ ಫಸ್ಟು ನೋಡೋಣ, ಚೆಕ್ ಮಾಡೋಣ. 1 minute ಮೇಡಮ್, 1 ನಿಮಿಷ. ಅಲ್ಲ ಇದು ಸ್ವಲ್ಪ ಇದು ಮಾಡಿ, ಇನ್ಫ್ಲೇಟ್ ಮಾಡಿ. It's okay, we'll do it. Okay, madam, fix ಮಾಡಿ. It is out in well below. Okay. Oh, 1 minute, let them finish. Gas ತಗೊಮ್ಮ, give me the gas. Yeah. ಇಲ್ಲಮ್ಮ, ಗಾಸ್ ಕೊಡು, ಗಾಸ್ ಪ್ಯಾಡ್ ಅಲ್ಲ, ಗಾಸ್. ಕೊಡಿ, ಅಷ್ಟೊಂದು ತಿಕ್ಕಬೇಡ. ಸ್ವಲ್ಪ ಲೀಕ್ ಇದೆ. ಸ್ವಲ್ಪ ಟೇಬಲ್ ಹೈಟ್. ಸ್ವಲ್ಪ ಲೈಟ್ ಮಾಡಿ, ಟೇಬಲ್ ಐಟಮ್ ಮಾಡಿ. ಓಕೆ, ಓಕೆ. So, laryngoscope, one second, endoscope. So once you introduce the laryngoscope, wide bore laryngoscopes, as Akshay morning showed that before proceeding surgery, you have to analyze the depth of the lesion completely, and as far as the malignancy is concerned, you look for anywhere else the lesion and how far it has extended. But in a benign lesions like this, it is always better to have a closer and magnified view of the lesion with the endoscopes, 0-degree endoscopes. So this looks like a polyp on the right side and a contact lesion on the left vocal fold. Suction. So do a thorough section, and the tube is well below the vocal fold, and so this is a closure endoscopic view of the lesion on the right vocal fold. It has got a lesion on both the vocal fold, more so on the right side. Okay.
Sir, you will be removing both the lesions or?
Yes.
Right?
No. We can remove. We can go ahead and remove. Only thing is, the lesions are not at the same site.
Okay.
It is on the left side. It is below, slightly below compared to the right one. But many of the textbooks and this one, they say that both lesions should not be removed at the same time to avoid cynic. But you can put a different incision and remove.
Make a flap.
You can, your incision will vary, sir. You preserve the medial most part of the mucosa, one side. If you preserved well, then other side you can go ahead and do it. Microscope switch on. Connect. So any so they are making connections, they are connecting it. So before that, see, there are the three basic principles of phonomicrosurgery is 3 M's. How you can remember is 3 M's. One is maximal preservation. 1 M is maximal preservation of normal mucosa. Second one is minimal disruption of the SLP, superficial lamina propria. Minimal disruption on superficial lamina propria. And third thing is mucosal trigone. Avoid injury to the mucosal trigone. These 3 M's is most important, and these are the basic phonomicrosurgical principles. So these 3 things you have to keep it in mind before proceeding into
Right,
the surgery. And as much as possible in a phonomicrosurgery, avoid injury to the anterior commissure and posterior commissure.
Sir, is there any role of laser in Ricci's edema?
Definitely. You can just put a incision for making an incision, especially on the superior surface of the vocal fold, yes. But for removal and all, you have to use a suction and remove the exudous material from the submucosal area. Head and ಸ್ವಲ್ಪ elevate ಮಾಡು. ಮಾಡಿ ಮಾಡಿ ಒಂಚೂರು ಹಾಂ ಏನಪ್ಪ ಸಾಕು ಸಾಕು ಮಾಡಿ ಇದು 400 mm ಲೆನ್ಸ್ ಅಲ್ಲ ಫೈನ್ ಅಡ್ಜಸ್ಟ್ಮೆಂಟ್ಸ್ ಇಲ್ವಾ ಈಗ ಕಾಣುತ್ತಾ ಫಾರ್ ಐ pressure visible now. ನೋಡ್ತೀನಿ ನೋಡ್ತೀನಿ ಯಾವುದು ಇದಾ ಸಕ್ಷನ್ right. It's a surgeon's choice. You can use either neuropathy or a ribbon gauze. Small piece of a ribbon gauze can be used, and this will cover the tube below the glottic region. Video. Okay. Injection. So with the instrument you can just palpate the lesion so that you will get to know whether it is deeply attached or just above the mucosa. So this is a polyp from that area. So you can go ahead Oh, it is not focusing. Ultra pulse only, yeah. ಸ್ವಿಚ್ ಆಫ್ ಮಾಡಿ ಮೈಕ್ರೋಸ್ಕೋಪ್ ಚೆಸ್ಟ್ ಮೈಕ್ ಸ್ವಲ್ಪ ಡಿಮ್ ಮಾಡಿ ಹಾಂ ಹಾಂ ಇವಾಗ ಸ್ವಲ್ಪ ಇನ್ಕ್ರೀಸ್ ಮಾಡಿ ಹಾಂ ಬಿಡಿ ಇದು What is the beam size? Ultra mode dot. It could be incision line. Focus ಮಾಡಬೇಕು here. So here focusing with the micro manipulator, there is a fine adjustments in the micro manipulator. Fine adjustments ಇಲ್ಲ. Okay. Sharing it collection. So I am using a Q blade. The features on the monitor, that is ultra pulse mode with accu blade and power of 6 watt. Yeah. 2 watts, sorry, power of 2 watts, and size of the 1 millimeter. So 1 millimeter size of the blade. So here I am using the blade. Earlier Akshay used the point, acute point. So I am using the blade to put the incision very close to the lesion. ಏನು ಕಡಿಮೆ ಆಯ್ತಲ್ಲ. Okay. So ಇದೆ ready. So once you are using the blade, stick, it can move. So you can see the incision there. Again extend the incision down. So your hand should be out of the joystick when you are putting an incision or when you are lasing the tissue. And this can the joysticks can change the angle of the blade. ಆಗ್ತಾ ಇದೆ. ಸಾಕು. Ready? Suction. So you can see well the incision which we have put now. Boucher's forceps, a triangle forceps. Yeah? ಸ್ಟ್ಯಾಂಡ್ ಬೈ ಇದೆಯಲ್ಲ, ಲೈಟ್ ಆಫ್ ಮಾಡಿ, ಸ್ಲೋ ಮಾಡಿ, ಈಗ ಬಿಡಿ. ಓಕೆ. Ready? ಆಫ್ ಆ್ಯಂಗಲ್ ಚೇಂಜ್ ಮಾಡಿ, ಇನ್ನು ಸ್ವಲ್ಪ, ಇನ್ನು ಸ್ವಲ್ಪ, ಹಾಂ ಓಕೆ. ಸೊ ಇನ್ಕ್ರೀಸ್ ಮಾಡಿ ಬೇಕಾದರೆ. That is, so there is a blood, as Akshay said, you remove the blood scar or blood stains, so that will hinder the laser procedure. So always whenever you are doing a laser surgeries, remove the blood clots or blood stains on the lesion or on the normal procedure. So just keep cottonoids impregnated with adrenaline solution, adrenaline normal saline solution. So this will moist the area. If at all, if you have heat, you might have generated the heat, so that will keep moistening the area. And second thing is bloodless field. It will give a bloodless field because of the adrenaline the cottonoids impregnated with the adrenaline. It will give a bloodless area. So this is the advantage of using these cottonoids in between the procedures. Leave it for 1 to 3 seconds, and then you proceed with the so the reduce ಮಾಡಿದ್ದು ಲೈಟ್ ಇಂಟೆನ್ಸಿಟಿ ರಿಡ್ಯೂಸ್ ಮಾಡಿ. ರೆಡಿ? Suction. You have to be very, very patient while doing these procedures when you are doing it under laser. ಆಯ್ತಾ? ಅಕ್ಷಿ ಸ್ವಲ್ಪ ಅಕ್ಷಿ ಸ್ವಲ್ಪ ಪ್ರೆಷರ್. ಹಾಂ ಸಾಕು ಸಾಕು. ಇದು ಕೊಡು, ಲೈಟ್ ರಿಲೀಸ್ ಮಾಡು. ಹಾಂ ಏನು ಬೇಡ ಬೇಡ, ಸಕ್ಷನ್ ಕೊಡು. ಹಾಂ ಭೀಮಕ್ಕು ಇದೆ. ಹಾಂ ಹಂಗೆಲ್ಲ ಕರೆಕ್ಟಾಗಿದೆ. Since there is no ಕೊಡಿ, ಫೋರ್ಸೆಪ್ಸ್ ಕೊಡಿ. angle, change the angle. So you keep talking to the person who operates the laser machine and the nursing team. Change the angle. ಯಾವ್ದು ಮಾಡಿದ್ರಿ? ಲೈಟ್ ಆಫ್ ಮಾಡಿಮ್ಮ. Sometimes while you are doing a procedure, sometimes it will go out of your view, the laser light. So the best way to identify is reduce the intensity of the microscope light and then search for the beam. So once you get the beam, then you can again switch back to the intensity. Okay. Ready? Okay. Cotton. ಇದಿಲ್ವಾ ಸ್ಟ್ರೈಟ್ ಫೋರ್ಸೆಪ್ಸ್? So this is very, very important. Keep moistening the area. Butcher's forceps. Okay, ಸ್ವಲ್ಪ pressure. Change the angle. ಟಿಶ್ಯೂ ಇದೆ ನೋಡಿ. ಹಂಗೆ ಇಟ್ಕೊಡಿ ಅಕ್ಷಯ್, ಇಟ್ಕೊಡಿ. Guide. Angle change. Angle change. Little bit. Ready? वीडियो क्या laser light reduce madam okay angle change no vertical ಆಗ್ತಿದೆ horizontal ಮಾಡಿ ಹಾಂ ರೆಡಿ ಆಗ್ತಾ ಇಲ್ಲ suction okay cotton nuts ಅದು biopsy cottonoids ಎರಡಿದೆ laser ready okay sir no problem. So now we are done with the procedure. As Akshay said, we have to preserve and protect the inferior border of the vocal fold or the inferior surface of the vocal fold. So when you are doing a cold steel method, you will create a mini micro flap. In that way you can preserve the inferior border, inferior surface of the vocal fold mucosa. Same thing here also, try to protect the inferior part and avoid damage to the inferior part of the vocal cord mucosa, because that is the area where the mucosal vibration starts generating. So now we can have a closer view of the. So I have shifted from microscopic picture to ಇದು ಕೊಡು ಇದು ಫೋರ್ಸೆಪ್ಸ್ ಕೊಡು ಸಕ್ಷನ್ again this was also a grade 1 difficult laryngeal exposure. So we had little bit anteriorly, to approach anterior part was little bit difficult. forceps. See, almost you're done, and see, this is the flap which you have created. So you have to place it back like this, and that way you have preserved maximum normal mucosa. And this is this. So approaching in this area, it was bit tough. The laser light was not reaching properly, and your instrument also. So the right side that lesion was done, and probably this looks like more of a contact lesion. What, Akshay? Oh. Now we can put an incision and leave it. Instead of excising, you can just put an incision and leave it. So that will remove whatever that edema. See, this looks like more of an edema. Good. ಇದು ಕೊಡಮ್ಮ ಫೋರ್ಸೆಪ್ಸು. ಮುನ್ನೂರು ಪ್ಯಾಟೀಸ್ ಕೊಡಿ. Change the angle. Patties ಕೊಡಿ. Change the angle. Make it vertical. Okay. Laser ready. So I'm just putting an incision. It could be early in case edema because ಇದೆಯಾ ಫೋರ್ಸೆಪ್ಸ್ ಯಾವುದಿದೆ? ಸ್ಟ್ರೈಟ್ ಫೋರ್ಸೆಪ್ಸ್. Yes. Okay. Incise ಮಾಡಿದ್ದೀನಿ. Just remove. We have incised, we have put an incision and we have incised, removed a thick kind of a glue was there. It is myxomatous material, we call it as submucosally. The exudate which will be there on the superficial to superficial lamina propria. That space is called the Rinke space. One minute. Enma? What ma? No, it's okay. Oh, wait. The sickle knife is there? ಇಲ್ಲ ಇದೆಯಾ? So on other side, instead of making it raw on the correspondent site of the vocal fold, you can just put an incision in the superior surface and remove as much as possible the exudate which is there. It is mainly the exudate because of the reaction. Anyway, so that's so I am using a sickle knife here to prevent in creating a raw surface. So just put an incision and removed whatever the exudate was there. Probably this could be a reactionary edema due to contact lesions, or it's see. This is a microscopic picture. This is the redundant mucosa what you see here, which I have preserved it so that it should not so that to respect the phonomicrosurgical principles. See, this is the reactionary edema. The fluid is coming out. So it usually you can have a closer view, endoscopic picture. So now you can see both the side. I have put the incision and most of the exudate has come out on the left vocal cord. Little bit is left. Anyway, it will go with that. Rather than disturbing the entire mucosa like how we did here. So it is better to preserve the medial most part of the mucosa. So I have put the incision superiorly so that whatever that exudate that has collected to come out, and here the completely the polyp has been removed. The suction madam, wipes kodu, wipes, cotton whites. Okay. Any questions? Cotton whites?
Okay, Krishnamurthy, good demonstration. Thank you very much.
Thank you, sir. So you can have a final picture after removing the clot. Okay.
Have you come across any case of synechiae post-operatively?
And if at all, if you have disturbed the anterior commissure area, mucosal trigone area we call it as, both the side, if at all if you have created a raw surface, then otherwise with this thing you will not get synechiae, sir. Because on other side we have respected and preserved the mucosa, medial surface, medial surface of the mucosa of the vocal fold, and here of course we have removed the lesion, so you have created a raw area. So this side you have preserved it, so no way the formation of synechiae will be there. So the tube is secured with a methylene blue, you can see here, sir.
Yes, yes.
And second thing is here the aluminium foil which they have used just above the cuff. So that will also protect the tube from getting fire hazard. Okay, suction. So the manipulation of the instrument is very, very important in phonomicrosurgeries. So you have to use judiciously.
Anytime you used microdebrider?
No, sir. No. The microdebrider, they say that if at all if an extensive laryngeal papilloma, the microdebrider is the best tool.
But Veerbhadra says you always use microdebrider.
Yeah, it's the best tool for this one, sir. Papilloma, laryngeal papilloma. I don't know. I don't have any experience with the for the cyst or the polyp.
I think we'll have a lunch break.
Okay, sir. Let's just carrier. ಕಾಟನ್ ನೈಟ್ಸ್ ಎಲ್ಲ ಬಂತಲ್ಲ. We just showed that.
ಹಲೋ ವೀರಭದ್ರ, ಹಲೋ, ನೀವು ಮಾತಾಡೋದೆಲ್ಲ ಕೇಳ್ತದೆ, ನಿಮ್ಮ ಸೀಕ್ರೆಟ್ಸ್ ಎಲ್ಲ ಅಲ್ಲಿ ಆಫ್ ಮಾಡಿ.
ಥ್ಯಾಂಕ್ ಯು.